Good morning, everyone. My name is Maya Luria with TMC for Seniors, and today is Diabetes Day. So we've got two presentations for you this morning. Our first one is on cardiometabolic care and how it impacts diabetes. I have Dr. Cynthia Rivas with me here. She is with our TMC Specialty Clinic. She's an endocrinologist over at TMC. And I'm so pleased that you were able to join us today, Dr. Rivas. How are you?
Yes, I'm doing well. Thank you. I'm
Good.
happy to be here.
So, Dr. Rivas, I've gone ahead. You've got an online audience watching. So if you are watching from home, please go ahead and if you've got questions, please put those into the chat and we'll address those afterwards. I'm going to go ahead and turn it over to you, Dr. Rivas.
Okay, perfect. Well, good morning, everyone, online and in person. I'm Dr. Rivas. I'm one of the endocrinologists that work here at TMC. I'm originally from Venezuela, so I speak Spanish and English. I did my med school in Mexico, then I came here, and I stayed here in Tucson. So I'm not planning to move, so I'll be here if you guys have any questions or want to see me. And I'm here to talk to you about something that's very important that I think we are missing a lot of information about it. So about cardiometabolic disease and how does it impact type 2 diabetes mainly. So first, I'll tell you, what's type 2 diabetes, right? Which is a chronic metabolic disease. And basically, there's a lot of insulin resistance. And as the time goes by, there can be a beta cell dysfunction. What are beta cells? Beta cells are the ones that make insulin in your pancreas. So as you progress to having diabetes for a longer time, then the beta cells start to be dysfunction, and you can have more insulin resistance, or you'll see that your blood sugars can go even higher than what they were 10, 15 years ago. And then also, what's cardiometabolic disease. So it's something that how would I say, it is a lot of things together. For example, it includes things like cardiovascular disease. It includes something that's called metabolic syndrome, insulin resistant, high cholesterol or hyperlipidemia, hypertension, obesity, and also diabetes. And more recently, there's new papers that they also include chronic kidney disease in this whole cardiometabolic, syndrome, basically. And so why is this important? Because patients who have type 2 diabetes, they are at substantially higher risk to having a cardiovascular event. So that's why it's so important. So what are the numbers? Like, why are we saying all of this and why is it important? So cardiovascular disease, it is actually the leading cause of death and major cause of heart attacks, strokes, and disability for patients that have type 2 diabetes. And it can affect about a third of them, a third of people who have type 2 diabetes. And so because of that, if you have diabetes, you can have about two to four-fold risk of having a heart event. So that's why it's so important. That's why we want to make sure that we target those risk factors and get them better. What are those risk factors? Like I mentioned before, if you have high blood pressure, if you have dyslipidemia, if you have in your cholesterol panel a low HDL, which is the good cholesterol, and a high LDL cholesterol. If you have obesity, and if you have insulin resistance, and if you're smoking as well, it's also another risk factor for it. What are other risk factors that we also should ask about? First, how old is the person? Do they have type 1 or type 2 diabetes? And how long have they had diabetes for? Why is this important? Well, first of all, because if you have a person that is, let's say 35 years old and it was just diagnosed with diabetes versus someone that is 70 years old and have had diabetes for 10, 15 years, their risk will be different, right? And then also if you have a person that has maybe 25 years old and has type 1 diabetes versus one that might be 35 years old with type 2 diabetes, the risk is different. Why? Because a lot of patients, because how type 1 diabetes works, it's basically your pancreas is not making any insulin at all because of autoimmune, problems with your pancreas. So there's not a lot of insulin resistance in those patients. So the risk for having a cardiovascular event is a lot lower than if you had type 2 diabetes. And, another reason is because some patients that have type 2 diabetes, they will also have other risk factors like the ones that I talked to you about. So that's why it's also important to know how long have you had diabetes for. So how do we screen for it? So this is, coming to your primary care physician office visit. They check your blood pressure, they measure you, they tell you how much you weighed. So they will tell you what's your BMI. BMI is what we're using right now to say if you're overweight or if you have obesity. In my opinion, it's not like the best way to determine if a person is healthy or not, but it's what we have right now. So I think in the future, I think there are going to be other measures of, being having obesity or being overweight in a better form to look at the whole thing, not only like a BMI and weight, right? But that's what we have right now. And then when they check your blood pressure, ideally, we want your blood pressure to be like normal is 120 over 80. But if it's more than 130 over 80, then that's already a hypertension diagnosis. There are new guidelines from the American Heart Association that are saying that they actually want the blood pressure to be like at least 120 over 80 if you have high blood pressure. So that's another risk factor that we need to improve. And then on your cholesterol, like I mentioned, the high LDL cholesterol, which is the bad cholesterol. For patients who have type 2 diabetes, we want that to be less than 70 or less. Why? Because when they've done all these studies, they've seen that persons who have a higher LDL cholesterol, they are at higher risk of having a heart event. Okay, so that's why we want to keep those numbers lower. And then the HDL, which is the good cholesterol, when it's low, less than 35, then there's a higher risk of having heart attacks.
Right. So wait.
Do you want to wait for?
I was gonna say, so that's not what you want. That's what you don't want.
What you don't want, yes. So the low HDL, it's more genetic. There's not a lot of things that you as a patient can do to improve it. Sometimes the cholesterol medicines can help, and also exercise can as well. But if you have family history of heart attacks, you might have a lower HDL. And then the other thing that you will see on your lipid panel is the triglycerides, which would be a higher risk if it's more than 150. Okay, and then for the blood sugar, if your hemoglobin A1C it's more than 7%. Ideally, we want the A1C to be less than 6.5 if we can. Less than 7 is good, but less than 6.5 is better. Why those numbers? Because we see less complications in terms of like diabetic neuropathy, diabetic retinopathy, and even, the other like cardiovascular risk, strokes, we see less of that when your blood sugars are better controlled. And so this is what I've talked to you before. What does cardiometabolic disease entails? So it includes, in the cardiovascular area, it includes coronary artery disease, and that's even with or without a heart attack, meaning there's plaque buildup in your arteries of your heart. And then it includes also stroke and heart failure. It also includes peripheral artery disease, which is plaque buildup, but in your arteries from your legs. And then, as part of not the cardiovascular disease, but it also includes fatty liver, which now they changed the name of fatty liver. Now it's not fatty liver; it's metabolic associated liver disease. So yeah, they make it more complicated. So and we also have the chronic kidney disease part. Okay.
What is it? Metabolic what?
Metabolic associated liver disease. MASLD, masled. Yeah. They don't make things easy, right? Okay. So what can you do? You can ask your doctor about, how does your blood pressure look? How does your blood work look? Where should it be? And where should my weight be ideally? Or what is something that I can do to change it, right? And where should my blood pressure be at? And what do I need to do to improve that as well? And how can I lower my cholesterol? So all of those are things that you should ask your primary care physician, or if you have an endocrinologist, you should also ask that. I always encourage people to ask questions because it's so important, right? It's your health, so you should be on top of it. We should be too, but you also should be on top of it. Because sometimes we're running so fast that we just don't see things, right? So it's important that you guys bring it up as well. So what can you do to lower your cardiovascular risk? So we have two things, which is the most important, which is lifestyle modifications, and then we have pharmacological interventions, meaning medications. Ideally, we want to focus a lot on the lifestyle modifications. That should be the number one, always. So the American Heart Association recommends at least 150 minutes per week of moderate to vigorous aerobic exercise, at least over 3 to 5 days a week. What does that mean? What does moderate to vigorous mean? It means sort of like power walking, if your body is able to do that. We want your heart rate to go up when you're doing a walk, right? Because that's what it will keep it to that, higher. It will lower your cardiovascular risk. If it's not walking, it's, let's say, swimming. Swimming can also be a good exercise. Some other things that you can do, they might need to be adjusted to what you can do, right? If you have some limitations, some back pain, knee pain, those sort of things. And then something else that can also help a lot is resistance training. And this is so important because as we age, as we hit that, 60 to 65-year-old mark, we actually want to be sure that we are strong as we are aging, because we don't want to fall as we keep aging, right? And we want to be able to be stable when we walk. And so that's why the resistance training part is important. What is resistance training? Resistance training is, maybe doing some small weights at home, maybe getting some small weight trainings, flexion, extension with your arms or your legs. Also, if you get like maybe some wrist weights or ankle weights when you go for your walk, you can, use them, and maybe you can create some resistance when you do that. So those are things that you can add to your day to day, and that will help your muscles to be strong. And also, other good exercises are things that are not so low weight bearing, like, yoga, Tai Chi, Pilates. Those are things that might not be as bad on your joints and that you can try. So sedentary behavior, right, is something that will keep your muscles like still, and you will probably, as much as you sit in a couch for a longer period of time, then things go worse, right? So I want you to move around as much as you can and sit less, right? And why do I say that? Because there's been studies where we see that if you even move as little as 30 minutes per week of moderate intensity physical activity, it will improve your metabolic profile, meaning your cholesterol panel, your blood pressure, your weight even. And we see here, on that image there, that, let me see, how do I do that? You're in red, and up there it means that you can increase your all-cause mortality, but if you start moving more to the green side, it will decrease your all-cause mortality as you move more. So that's why it's so important. And so even if you increase your steps by 500 per day, it's an improvement. And then even the other thing is, if you do like a 5 to 6 minute brisk intensity walk per day, it improves your life expectancy by 4 years. So that's, those are things that maybe you can add up. Steps do matter. They've said if you walk 2,000 steps a day, it might not change much your cardiovascular risk. But if you walk up to like 5,000 per day, at least 5,000, then you can improve your cardiovascular risk. But if you walk more, like more than 5,000, there's not really a big change. So at least 5,000 a day, okay? And so how do we do to form the habit, right? You can start doing, things as you usually do, right? You have to take pills every day. You have to sleep at night. You have to brush your teeth in the morning and at night. And you have to drink water and eat healthy, right? So how do you add that up? You can start doing some activity every other day. Maybe start slow, maybe 5 minutes this day. And then the next week, you start going up maybe 10 minutes a day, right? Those are things that you can start doing slowly so you can actually form the habit of it. And then after what they say, 21 days, then you have the habit, so you should be able to continue with it. Let's see. So another thing that you can do is track your activity progress, and you can do a chart at home, in your computer, or even on a piece of paper, and see how many minutes are you walking per week, how many days per week are you walking, and you can do that week by week and see if you're actually seeing an improvement. I think that's something that can it can, how would I say this, encourage you to keep doing it, because you're seeing an improvement on how much you can do now. Okay. So you can be, a strong woman or man as you age, right? So my prescription for you is to exercise, okay? And then the other part of the lifestyle modifications is diet, right? So what diet is better for patients who have diabetes to lower your cardiovascular risk? So the American Diabetes Association recommends the Mediterranean diet, or a low carb and low glycemic index diet, plant-based, or the DASH diet. Mediterranean diet basically means that they use more good fats like olive oil, avocado, or avocado oil, less red meat, more fish, right? And same, that will go up with the low carb and low glycemic index diet. And they do, recommend more plant-based, more vegetables, fresh vegetables, fish, and then the DASH diet, which would improve your blood pressure, meaning you eat less salt, right? I mean, you guys might be able to say that better than I can. But yeah, I also think that it's important that there's no perfect diet. It's the diet that fits you better, right? The diet that you can do and be consistent on it. So it doesn't have to be a specific one. Maybe you mix a couple and then that's what works for you. So it has to be adapted to how much you need in a day of, kilocalories or not. And then I do think that at least once you should meet with a dietitian or a nutritionist just to talk of how much do I need of protein, where can I get this protein from, because that's also another thing that I see in as we age, that people are not eating as much protein that they need, and then that also, you're not getting what you need as you age on protein. So this is like the Mediterranean diet pyramid. Basically, it starts, less red meat and sweets, and then you have some chicken and cheese and yogurt, moderately, more fish, right, and seafood, and then a lot of vegetables, fruits, vegetables, olive oil, beans, nuts, legumes, herbs, and spices. So basically, in your everyday meal, you should include that. And then the other are just like add on, maybe every other day. And then part of the Mediterranean diet is also, or like the lifestyle, I would say, it's be more physically active and be part of a community and enjoy meals with other people. That I don't know if you've seen like the Blue Zones. There, it's like a book, and then there's a show on Netflix that they talk about the Blue Zones and how are people, getting older to like 100 years. And there's a city in Italy and in Greece, where they talk about this. So it's so important. And in some places, it's just even being part of a community. It helps people also like being, live longer and, not being lonely, basically. And also, your diet. So my prescription is also eat a healthy diet for you. So what are some medications? Now we're talking about medications. So for patients who have diabetes, we have newer medications that help lower your cardiovascular risk and also lower your blood sugars, right? And so we have two kinds. One are called GLP-1 receptor agonists. And those are, they're very popular right now. But those four that I put there, those are the only ones that have the cardiovascular risk benefit. Those are Victoza, Ozempic, Rybelsus, which is new. It's not a new medicine, but it got a new FDA approval for cardiovascular risk reduction. And then Trulicity. So the American Heart Association, they recommend these agents for patients who have, history of cardiovascular disease, like with coronary artery disease, heart failure, or even in patients who have chronic kidney disease. And then we might even consider adding one of these medicines, even if your blood sugars are okay. Why? Because we want to lower that risk as much as we can, because we know it's a higher risk in those type of patients. So I'll just talk to you briefly about the medications. So the GLP-1 receptor agonists are those that I mentioned. So how do they work? So what is the GLP? GLP, they're natural hormones that we make in our body. They're specifically in your stomach, close to your pancreas, and we also have some of them in the brain. Why do they help? They help in our normal person. We make GLP-1. We make the GLP-1, but when we have diabetes and insulin resistance, that GLP-1 secretion goes down. So what does the medication do is just improve your own GLP-1, so you can lower your blood sugars only after you eat. If you don't eat, the medication doesn't work. So the same receptor is in your brain, and so in your brain, it actually acts in your appetite and satiety hormones, where it can lower your appetite and it will increase your satiety. So that's how people who take these medicines, they're really not eating as much as they did before. And that is sort of how people start to lose weight. Okay, that's also another added benefit. So yeah. And then we have the other ones called SGLT2 inhibitors, the dapagliflozin and empagliflozin, Jardiance or Farxiga. So these medications actually work in your kidneys, and they help your kidneys getting rid of the blood sugar through your urine. So it does work a little bit like a diuretic, like a water pill. And if you take those, you might notice you're peeing a lot, and it's because of how it works. It can also, as it lowers your blood sugar, it also lowers your blood pressure, and it improves your cardiovascular risk. And now patients are even using it if you have heart failure, because it keeps patients out of the hospital when they have heart failure and they're taking this. So it is a very good medication to take. And it also prevents from your kidney function to keep getting worse if you have diabetes. Okay. And then these are the old ones that we know about them a long time, right? Statins. A lot of people they are scared of taking statins, or they think it's not good for them. But I do think that they are good medicine. We should probably have it like in water. Everyone should take a statin. Why? Because we want to help people lower their cardiovascular risk. And it helps lowering your LDL cholesterol, the one that we want to be less than 70. So that's why when you have diabetes, that's why some doctors might tell you, oh, you need to be on a statin. Why? Because we want to lower that risk of you having a coronary artery event. And then other medications that we have are also the ACE inhibitors, like lisinopril, ramipril, or the ARB. Those are losartan, olmesartan. Those are blood pressure medications. But when someone has diabetes, it can also help getting rid of that protein in the urine called microalbumin, that some patients with type 2 diabetes, they can start spilling if it's uncontrolled. And so these medicines will help lower that protein in your urine and the kidneys, and that way it will also lower your cardiovascular risk. Okay. So the risk factor management remains fundamental, right? We want your blood pressure control to be at least less than 130 over 80, and now most recently less than one, or at least 120 over 80. We want to control your cholesterol. I want you to stop smoking, and the weight management part, and the diabetes control. So all of this is very important to improve your cardiovascular risk or reduce your cardiovascular risk. So in summary, early identification opens the door to prevention, basically, right? So we want to prevent things. This is how we prevent things. Moving, working on your diet, and then the medication part comes along if needed. Okay. So we know that the cardiovascular disease is a prevalent and early complication of type 2 diabetes. And if you can achieve multifactorial risk reduction with what I've told you, you will lower your cardiovascular disease event by 50%. So that's very important. So start walking, doing some resistance, small weight training, start slow but steady. Have healthier food choices and have uninterrupted sleep. That's very important. And then ask your doctor about what medications you can take that can lower your cardiovascular risk even more, especially if you have a history of, like a heart attack or a stroke or heart failure. Those are things that we didn't have those things, like the medications, like 10, 15 years ago. So now that we have them, we really want to take advantage of them and have the right patient on them. Okay. And this is a picture of one of my favorite places in my country. It's Margarita Island.
You didn't mention Actos, that's all I think.
Yes. So Actos is a medication that it's an old medicine, but the data doesn't really show that it does improve your cardiovascular risk. Yeah, so it doesn't. It can help. It does help with diabetes, but it can help with fatty liver if you have fatty liver. So that's also a good thing. So yeah, and it will help with diabetes as well. It doesn't lower your cardiovascular risk. No, not for your heart. No. Yeah.
We'll do online questions first.
Oh yeah.
Yeah, thank you, Dr. Rivas. So I do have some questions that have come in, and quite a few regarding GLP-1s, and maybe what are the side effects to using a GLP-1?
Yes. So because of what I was saying, that the medication works in your stomach, the most common side effects is that people will have nausea, and you can also sometimes have vomiting. Why does that happen? Because the medication also makes you feel fuller faster. And so, for example, if you're eating something like red meat, that's something that's very heavy on your stomach, and you keep eating, and your body's telling you that you're already full, but you want to keep eating, then you get, well, it's like bloating, nausea, and it's just like you feel sick all the time. So that's one. The other one is it also slows down your metabolism in your GI tract. So a lot of people can have constipation. A lot of it is also because we are not taking as much fiber in our diet as we should. And so if we don't have enough fiber, then this side effect of constipation will be even worse. So adding some fiber in your diet will help the constipation. Making sure that you're drinking enough water is another one. But we also have to be aware of, let's say you do suffer from constipation before you started this medicine. So if you are gonna try them, then you need to be careful and be sure that you have frequent bowel movements, at least one a day, because there has been some rare, not very common reports that sometimes people can have like a small bowel obstruction because you just, your body, your GI tract just stop working. It's not moving when people take this medicine. So you have to be very careful, cautious about that. And then let's see. There are some patients that they say it's not that common, but because of that receptor on the brain where you have sort of like your cravings, your appetite, we lower that a lot. Some people can actually feel like sort of like depressed. It depends on the person, but I've had a couple of patients that do tell me they feel a little bit depressed when they take them, so it might not be the medicine for them then, so but some people actually feel a lot better. It also has other benefits in your GI tract. I don't know if you guys have heard about the microbiota. The microbiota is, all the good things that we want in your GI tract, right? And how do we improve our microbiota with the things that we're eating? That's connected to your brain, to your, mind, and so the medicine, there has been some studies that they say that the GLP-1 receptor agonist helps your microbiota. So some people might actually feel better, and your GI tract will also be better.
Great. Now, is there, how long should somebody remain on a GLP-1? I know that these are new and maybe there's not a whole lot of research, but if you start one, is that something that you're going to be on for life now, or is that something that you try to get people off at some point in time?
Yes. So the GLP-1s like Victoza, for example, that one has been out in the market for over like 15 years or more. So we know that, and the Ozempic has been also maybe like 10 years already. We know already that they've done like prospective studies showing that, this medication doesn't increase the risk of like thyroid cancer. That's one of the things that we worry. It doesn't. And once we start this medicine, if you're really doing very well for your diabetes and you would keep your A1C well controlled, then I would be mindful of stopping it because you are well controlled, because you're on the medication and also following your lifestyle modifications. So I wouldn't want to stop something that, might want to increase your A1C again, right? And so it depends a lot on the patient, like how much of their part they can do. Or, even if you do a lot of good things, eating healthy and everything, because you've had diabetes for such a long time, sometimes that's not enough. Like you need more help, right? So yeah, so a lot of the times we do continue them, lifelong. And if we can, we will always, or I will always lower the dose that you're on if we can, to see how does your body works with it.
Great. Okay. And now, is there, how often should you have your A1C checked?
We should check your A1C every 3 months.
Okay. Now, I had another question come in about metformin and the effects on the kidneys and AFib. Can you share anything on that?
Yes, so metformin, that's one of the medications that have been out in the market for the longest. And so there is some data that says that, well, it might help to lower your cardiovascular risk, but it's not good data. So it's a maybe it helps. When someone has chronic kidney disease, we need to dose this medication for your kidney function. Why? Because it doesn't get excreted as you should. If you have a lower, like a chronic kidney disease stage 3, that's when we need to start changing the dose of the medication. Because of if we don't, then you can actually cause harm to your kidneys if they don't change the dose. But the medicine itself, it shouldn't cause kidney disease. Like if you have a normal function and they start you on it, it shouldn't cause, kidney disease.
Okay. Now,
And yeah, I don't know.
sorry, go ahead.
I don't know about the AFib part. I'm not sure about that.
Okay. Also, somebody asked about, are there reasons that someone wouldn't be a good candidate to maybe start a GLP-1?
Yes. So if you've had any episodes of pancreatitis, inflammation of your pancreas, nausea, vomiting, a lot of abdominal pain, that you ended up in the hospital, then you shouldn't take this medicine because it can cause pancreatitis. And then there is something else called medullary thyroid cancer. So if you have any family history with this rare type of thyroid cancer called medullary thyroid cancer, then you shouldn't take these medications. Not the other kind, or not. It's okay if you have like thyroid nodules and they're not suspicious and there's no family history of this type of cancer, then you should be okay to take them. Yeah.
Okay. Now, Dr. Rivas, if somebody wanted to come in to see you, do they require a referral for that appointment?
Yes, we do need the referrals to be sent, and like an A1C at least from your primary care physician. And then I'm not taking new patients right now, but I'll start like next month. I'm gonna.
Okay. And what is? Can you tell me where the office is located?
Yes, it's on Ferguson. It's across TMC Hospital. So it's when you come from Grant, that's where Ferguson is before Craycroft. That's where our office is.
Okay, so just across the street on Grant, right across from the hospital. I do want to put your phone number up as well. If they were interested in an appointment down the road, the phone number is 520-324-1010. Dr. Rivas, I want to thank you so much from our online audience for being here today. I am going to wrap up with them and I'm going to turn it over to you for anything in person. Thank you so much for being here.
Yes.
Thanks again for joining us for our first presentation today. We will be back at 11 a.m. for Core Confidence, Enhancing Circulation, Strength, and Stability with Diabetes. That is 11 a.m. today, Wednesday, November 5th. We will see you soon. Thank you.